Welcome everyone to tonight's webinar. Tonight we're going to be joined by Associate Professor Nigel Crawford and Dr. Bryn Jones, a cardiologist from the Royal Children's Hospital. And we're presenting the health pathway and sort of primary care management of myocarditis and pericarditis after the mRNA COVID-19 vaccines, which is Pfizer and Moderna. Before we start, I'd like to acknowledge to the country, and in the spirit of reconciliation, we acknowledge the traditional custodians of the country throughout Australia and their connections to land, sea and community. We pay our respect to their elders past and present and extend that respect to all Aboriginal and Torres Strait Islander peoples today. Just letting you know, the webinar is being recorded and all the attendees are muted. There is a Q&A function at the bottom of your Zoom page where hopefully you'll be able to ask some questions. Hold on till later in the talk because many of your questions hopefully will be answered as we work through the presentation. And slides will also be circulated to the attendees. So this is the schedule. Basically, we're going to start with Associate Professor Nigel Crawford, and then I'm going to present the health pathway, followed by Dr. Bryn Jones, who might be regretting moving to Melbourne because Bryn originates from Queensland. So I'm sure he's going, what am I doing here after what we've been through the last year or so? But anyway, and then we're going to have a question and answer time. So next slide, please. So we'll hand over to Associate Professor Nigel Crawford for a little bit of background. Thanks, Nigel.
No, thanks, Scott, and thanks for the invitation from Health Pathways to go through this. So, yeah, I'm Nigel Crawford, and just a bit of a declaration of interest. So I'm work at the Children's Hospital, similar to Bryn, also at the University of Melbourne, and a group leader at MCRI. Next slide, please. And as a declaration, I'm also currently seconded to the Victorian Department of Health. So I'm giving some advice there as a senior medical advisor to their safety team, and also a member and going to be the incoming chair of ATAGI. So just always with these presentations, make clear that these are my own views and not necessarily those of my affiliations, and I have no pharmaceutical industry declarations. Next slide, thanks. So as Scott outlined, I'm just going to take you through a bit of a background of myocarditis and pericarditis associated mRNA vaccines, with obviously pericarditis being inflammation of the lining of the heart, and myocarditis inflammation of the heart itself. And then there's the overlap, those that have both myopericarditis. And next slide. We'll just take you to a bit of information around, where this signal emerged and came from in some of the early data. And essentially the first we heard about this as a signal came out of Israel, which is a country I'm sure many will have read. We've run essentially a Pfizer program from very early on. They did have a prioritization schedule, rolled down to different age groups and got very high coverage very quickly, and had some early reports around myocarditis and pericarditis associated with that mRNA vaccine. It's subsequently been seen with Moderna, which, as Scott mentions, off the same platform. That's just started in the pharmacies, and some also being out of immunisation hubs in the southeast of Melbourne and other parts around the country. So we know that both of these vaccines are associated with this, what we call an adverse event of special interest, because we were looking for this before the vaccines rolled out. So in different to the thrombosis and thrombocytopenia syndrome, or TTS, which Scott also helped bring together a pathway, and we had a similar presentation probably a few months ago now, but time goes pretty different in the pandemic. But that was an unexpected combination of thrombosis with thrombocytopenia. This is something we're expecting because we've obviously seen it with the COVID-19 infection itself, where you can have pericarditis and myocarditis associated with SARS-CoV-2 infection. And we have seen this signal with the vaccine. The US, through their ACIP, give regular updates. The link there is a detailed presentation, which I'll now show you some slides in terms of the early data coming out of the United States. Next slide, please. So this is really looking at this window. So what we heard was this reaction was occurring. It was occurring quite quickly post the vaccine. And in the left-hand column, you can see the age range and the number of cases of what you might expect in that age group versus what's observed. So this is in that window of a week post the vaccine, they might have expected 0 to 3 cases, but they've actually seen 12 in that female age group at 117 in the males. So the main risk factors that are coming out, that this is predominantly second dose and predominantly in males. The highest peak is into that under 30 age group, but there are some cases still seen in other age groups. And just being clear, this is only myocarditis or inflammation of both the myocardium and pericardium, which is much more the pointy end or tip of the iceberg, which we can measure. The pericarditis a bit more complicated, which I might get Bryn to explain some of that later on. But next slide, please. Again, a really busy slide, but the US have run with both of the vaccines, so Pfizer and Moderna, and Janssen is their third vaccine, which is off the adenoviral vector platform, so similar to AstraZeneca, but it's a single dose, hence that only dose 1 is being seen there. And what they've done here is all these reports that have gone to their spontaneous reporting system, which for us in Victoria would be SafeVic or nationally collated through the TGA with their weekly report, is now giving some rates of myopericarditis. We can determine the rates dose 1 and dose 2 with those vaccines. And in the next slide, if we can go to that one, I've just pulled out that by age range. As mentioned, we're interested in both the rate and the age and the peak, and also the comparison between Pfizer and Moderna. Are they equivalent? They've both got a lipid nanoparticle covering them. As an mRNA vaccine, they're carrying that spike protein and reactivating, but uncertain at the moment exactly what the pathophysiology is. But essentially the rates at that 18 to 24-year-old is equivalent. We hadn't yet licensed the vaccine in the US for the 12 to 17, so limited data there, but we will get some more shortly out of Canada. The highest rate, as you can see, is 71 per million or 7 per 100,000 in that 16 to 17-year-old. So still a rare adverse event of special interest at a maximum of around 1 in 15,000 doses from this data. And this is from August. Next slide, please. And this is then looking at that same data. I mentioned over 700 cases. They've given over, in the 12 to 17-year-old age group, nearly 55% have had a dose, or 45% have now had 2 doses. There's over 10 million doses in the adolescent age group. So a really big volume of vaccine being given in these population to help us understand the epidemiology. And this slide just shows you the cases on the left and then the days post the vaccine. And really within the 7 days, we're seeing majority of cases. Some have been delayed, but certainly that first week is the main time we expect to see the cases. Next slide, please. So then how do we get more information on these cases and how do we approach them? And one of the key things that's been flagged is that it's particularly in the pediatric population. So now we're running a 12+ program for healthy adolescents. We're running blitzes in year 12s. I know over 50% of year 12s in Victoria were vaccinated very quickly. Similar, I know, New South Wales and other jurisdictions who've done things similar in South Australia and Tasmania, who I know also use the health pathways. So we've worked closely, and Bryn and I were both involved in this with the Predict Network. So Franz Babbel, Simon Craig and Stuart Dalthalsian in New Zealand helped put together this guideline with the Australasian College, just to say, how can we evaluate or get more information in the emergency department? Next slide, please. Just shows you their flow. So again, I think Scott's going to take you through the health pathway, but traditionally in pediatrics, we didn't do that many investigations for chest pain in the ED. Normally you'd think it's non-specific or post-viral infection, but if someone does present in that week post the vaccine, we really want them to think about this as a possible diagnosis, do some more investigations and help us understand it. So working closely with our emergency department, primary care, GPs, and obviously our cardiologists is really important here. Next slide, please. So again, this is a little bit of a busy slide, but it's just showing that there are ways we try and categorize these adverse events in more detail. And this is the Brighton collaboration, which is the international group we use to categorize adverse events. And these are the features that we're looking for to say, was there a pericarditis case? Now, their highest level is always a biopsy, which predominantly is obviously never going to happen. So you start to get down into level 2, which is probable or possible cases, or level 4 when have some chest pain, normal investigations, but people think it's pericarditis. So that differentiation is going to be important as we start to think about revaccination. But essentially, I think the key point of this slide is that in the vaccine safety team that I help lead at SafeVic is that we really need quite a bit of information to confirm that diagnosis. Just some chest pain alone isn't going to allow us to determine, is it safe to proceed with dose 2 or was this pericarditis or myocarditis? So the more information we can obtain clinically, not over-investigating, but appropriately investigating when you have a clinical scenario is really helpful. And this is what we use, internally to try and understand and define these cases a bit better. And the TGA does the same. Next slide, please. So just a summary and sort of that clinical phenotype. Again, we're going to quite quickly to cover all of this. There is additional information available on different sites, but essentially it's the highest in young males with the second dose. Essentially acute onset chest pains being the predominant symptom, sometimes shortness of breath and other non-specific features. The cases we have seen to date are really following that international evaluation. The majority have had, particularly the myocarditis, have had elevated troponins, abnormalities on their EEGs, and some have had an MRI confirming a myocardial inflammation or edema, but an echo that's essentially in majority been normal, so normal function, been hospitalised for a few days, needed some anti-inflammatories, sometimes colchicine, which I believe is a bit more used in adults in the paediatric space, but variations in treatment, had some exercise limitations placed, and we'll have close follow-up in cardiology outpatients. So we are seeing some cases in Australia and we will closely monitor and follow them up. Next slide, please. So in terms of that outcome, again, this is back to that US data summary where they had over 1,300 cases preliminary, but 740 met that CDC definition, which essentially is very similar to that Brighton collaboration definition I showed you before. And again, this was one of the first studies we saw of systematic evaluation of the cases in terms of hospitalisation and outcomes. And 77% of those cases had recovered at the time of the report. They still had a few in hospital and a number in ICU. They're going to follow these cases up, obviously, more closely and monitor them over time, but essentially reassuring data in terms of that short to now sometimes medium-term follow-up. And as I mentioned, millions of doses of these vaccines now administered in the United States in particular. Next slide, please. So again, as I think, alluding to that sort of the clinical follow-up, but the summary is this is definitely an adverse event of special interest. It's not something that's been seen with AstraZeneca. We've looked here internally in Victoria and also in the national picture. The cases we've seen following AstraZeneca have been in what we call the background rate. So the expected rate have been seen, but not an increase with the AstraZeneca vaccine. As I mentioned, predominantly within that 1 to 7 days. And also no increase in some important groups. So the First Nations people, we haven't heard from our colleagues in the United States and Canada in particular in terms of increases there. Also no increase in those with congenital heart disease or taking medications such as ADHD stimulant medication or psychotropic. So they were flagged as concerns. We're not hearing about them. It appears in majority to be an idiosyncratic reaction without clear risk factors determining outside of age and gender, as I mentioned. Next slide, please. So what's unknown? I think a few questions came in before the presentation. So we don't know, quite a few things. So we clearly don't know what's going to happen with the third dose, and that's obviously a discussion that's happening here in Australia, but almost everyone would have seen the United States in terms of booster doses and recommendations, essentially going to focus on the immunocompromised healthcare workers and over 65s initially, but clearly in younger populations such as Israel, we're watching closely around any third dose, if that is another mRNA vaccine. Also uncertain the risk in 5 to 11-year-olds. And again, I know lots of questions coming about when are we going to have a vaccines in primary school. That could be a whole separate, presentation. We get a press release last week from Pfizer with some high-level sort of numbers, and they had 2,500 children. They used a lower antigen, a third less 10 micrograms of the spike protein for that vaccine. So clearly getting a good immune response, adequate safety profile, but relatively low numbers. So really got to wait for the FDA and those more details review, also the TGA. We do expect a decision to come before the end of the year from the FDA around the 5 to 11-year-olds, and clearly myocarditis, pericarditis will be something important to monitor. The pathophysiology also, currently unknown, assumed to be some sort of immune-mediated trigger, whether that's T cell is again uncertain. A few cytokines have been flagged in some of the early work, and I know the US, there's quite a lot of studies under investigation. Clearly some sort of priming potentially with dose 1 and then an exacerbation with dose 2 is a theory. And also genetic risk factors. So there has historically been another vaccine, the smallpox vaccine, obviously the only vaccine preventable disease we actually eradicated through vaccination, was associated with myopericarditis and seen in military recruits, as was this signal as well in the first instance. So that was a little bit different, a bit more delayed post the vaccine, but obviously interest in the genetic factors and what we might learn from previous investigations. Next slide, please. So in terms of the ATAGI advice, there has been obviously lots of input into this advice. in terms of, an approach which has guided some of the other resources, including the health pathways. This is in collaboration with the Cardiac Society of Australia and New Zealand, and got quite a bit of feedback from GPs and other sources that some of those precautions were being taken very literally. They weren't contraindications. They were more potential groups that may have some compromise if they were included, but they've now been taken off the latest updated advice, which is at that link you can see below there. So the same link to the advice is being updated and dated as those changes come through. And essentially those with a history of congenital heart disease, transplant or cardiomyopathy can receive the vaccine without a precaution. The only precautions that remain are those that have had recent inflammation, so particularly pericarditis or myocarditis in the past 6 months. We'd say talk to your cardiologist or GP around, is it safe to proceed, or do you need to think about that being activated or something occurring? So it's not saying you can't have the vaccine, it's more we want to generate a discussion if you've had recent acute inflammation. Next slide, please. So again, acknowledging Alan Cheng, who helped with this slide together, but again, we're obviously with all these things trying to discuss the risk benefit. And we think the benefit of the vaccine at a population level is clearly very important, both in terms of infection and long COVID and COVID-associated myocarditis. And at the bottom there's a paper from Israel that showed, as I mentioned earlier, that there certainly is myocarditis seen with infection, and that's been described in lots of studies now out of the United States as well. The vaccines will clearly protect the individual against severe disease and death, and it also does have that broader protection of communing those close contacts as well as elderly and immunosuppressed relatives. So the fact we've got a 12+ program where you can protect the whole family from that age and above, and that protection of the community. There are these rarer risks. So early on with the Pfizer and Moderna vaccines, we're worried about allergy, but anaphylaxis is actually very rare and around 2 to 4 per million, which is what we've seen with other National Immunisation Program vaccines. So allergy, very uncommon. Myocarditis, as mentioned, the rates around 1 to 5 per 100,000 doses, or an attributable risk of 3 additional cases per 100,000 in that time post the vaccine. So still a rare adverse event, but one we need to understand as we provide advice around vaccination, particularly the second dose. Next slide, please. So I think, just summarizing there, back to you, Scott. I think the key thing from the advice people having the vaccine is just to let them know that don't push on through the symptoms. We're not suggesting, major exercise reduction or anything, but if you do develop symptoms, particularly within that week post the vaccine, you do present to your GP, and hopefully the health pathway gives some direction around when to investigate and how. But I'll stop there. Thanks, Scott.
Thank you, Nigel. So Health Pathways Melbourne have developed a pathway. Next slide, please. Based around the ATAGI and the emergency guidelines, and also the Bristol guidelines. Now, just before we go ahead, I'll just let you know that Health Pathways, those of you that are aware of it, know how it has a bit of a clunky table of contents on the left-hand side. And if you look at this, we're about to launch a new mobile-friendly version of it, which will look a little bit better. So next slide. So that's what it's going to look like soon, and you can actually try that now. And as you see, the table of contents on the left is a little bit more sort of up to date than the more old-fashioned look on Health Pathways. So that's something you can start looking at now when you do use Health Pathways. So now we're going to look at the background, and this has been very well covered in Nigel's presentation, so we're not going to go too much into that. So next slide. And it summarises basically what Nigel was saying. Generally appears in the first 1 to 5 days and can be up to 2 weeks. And there's a little bit of definition of what myocarditis and pericarditis is, and some of the risk factors that we were talked about before. And then at the bottom, a further dose of the vaccine should be deferred following a diagnosis of myocarditis or pericarditis until basically consultation with SAFEC. So next slide. The assessment, so as with those of you that are unfamiliar with Health Pathways, it's basically an assessment and management and referral section. And the assessment, we're trying to make this as simple as possible. So what are the symptoms that are going to present where you start thinking that this could easily be the reaction to the Pfizer or Moderna vaccine? And the cardiac specific symptoms are chest pain, pressure or discomfort. And this is a pain that's made worse when lying down with deep inspiration and relieved by sitting up or leaning forward. And it's difficult sometimes to distinguish this from the pleurodenia pain that you sometimes get. The other symptoms are palpitations, syncope or dizziness, dyspnea, and also pain with breathing. And those are the cardiac specific symptoms. Just always remember with this, fever can sometimes be a presenting symptom. So certainly if they're febrile, then we're going to have to think about having a COVID swab, and that will obviously, where you're situated and how you manage that will be sort of very much an individual circumstance on whether you feel you're doing a telehealth and you said, yep, well, this is probably should be going to the emergency so that they can assess this in a more COVID sort of aware environment. Having an urgent swab is the first thing to do, because there could be COVID could present like this as well. Obviously, considering other causes of acute chest pain, particularly in the older age groups where this is a less of a common side effect, and we're thinking about other causes. And the examination is fairly self-explanatory. Tachycardia, unexplained tachycardia, is certainly a significant sign of myocarditis, and a pericardial friction rub. And then if you feel that you're able to, then perform an ECG. And I've got some examples there. And if we go to the next slide. And we've got some examples that when you click on that, you'll get to these pages. And this is what it is. It's showing in the lateral leads, the V5, you'll see PR depression and ST elevation. And in the mirrored lead on AVR, you'll see the opposite. Next slide. And with the pericarditis, you see a pulse rate of around 100, just over 150 there. And there's a little bit of ST segment changes. Next slide. So, but if you've got a mild symptoms, there's a young male, he looks very fit and healthy, not really, he's just got a bit of chest pain, your ECG is normal, and he seems okay, and then you don't have to send these guys to the emergency department. You're quite within your rights to order some bloods and to review the next day. And so, next slide. That's just an example of the water bottle sort of image of a nasty pericardial effusion, which I don't think we're going to see that very commonly. But the chest X-ray certainly you'd consider in the older age groups, and maybe some of the older in sort of the late 20s males. But I wouldn't necessarily, unless you're really concerned, be ordering it in some of the younger ones. But we might be doing a younger pathway if that's going to be necessary soon. Next slide. Now, so the management, so the first thing is going to the emergency department. Well, if they're significantly unwell, if the ECG is abnormal, or the blood tests you've done have got significant raised troponin levels, or there's an abnormal X-ray, or you're concerned about the differential diagnosis, common sense, send them to the emergency department. Next slide. Now, this is Mike, and myocarditis is clearly having a lot of chest pain there, and he's also having some dyspnea. And he's in slow motion, so I reckon he's quite tachycardic there. So this is a nice sort of a reminder of of the kind of distress that he would be in. And that's the cardiac specific symptoms, and that certainly is a sick person who would need to go to the emergency department to be properly assessed, and wouldn't be appropriate for a GP management. And the next slide. So so managing the community, this is the contentious area. They're not sick. They've got some chest pain. They have a normal ECG. The troponin levels, inflammatory markers, and they have minor symptoms. The current guideline in the emergency department for these guys is they send them home. So if you've got this, you don't need to send them in, because they'll send them home, and you can monitor them over the next couple of days. Maybe the next day, see them, repeat the ECG if you feel like it's necessary. And basically reassure and treat symptomatically, and review if necessary. There's not too much evolution that we're aware of following the first day or so of this. So it's not something that don't feel too concerned about this. I talked to the emergency physicians today at the Children's. They're sending all the kids home who come in with the adolescents who are coming in with chest pain, who have normal ECG, normal vital signs, and even if they've got significant chest pain, they're still sending them home and they have normal bloods as well. Next slide, please. This is the follow-up section in the management, and basically you're working with the cardiologist if they've had a significant episode, if they've had a significant episode, the cardiologist will obviously like to see them for at least 12 months, and avoiding high-intensity exercise until resolutions of symptoms if they've had an abnormal ECG and that normalises, and normalization of cardiac function from the cardiologist's point of view, and getting advice on what to do with the next doses of the vaccine. Next slide. So for those of you that have, this pathway has been taken up around Australia and even Tasmania, and obviously if you're not registered, then please register, because it also has got the TTS pathway, and also the other pathways we've got is what to say to people before they have the vaccine about this, and also looking at the kind of risk factors where you hesitate on doing the vaccination, which basically there is very little for this particular vaccine. Next slide, please. So just a reminder, with health pathways, there is a feedback section, and you can click on it if you find an error or would like to comment on something, and that gets to us, and then we will adjust the pathway if we feel that's relevant feedback. We sometimes miss errors, or there's links that are broken, and we don't always pick those up. So if you find anything, just send a feedback and we'll receive it. So next slide, and I think we're going to be heading over to Dr. Bryn Jones. Thank you.
Thanks, Scott, and thanks to yourself and the team for the invitation to speak tonight. Quickly, a couple of quick studies, adolescents that we've seen at children. Expect to see more come through as we roll out the second dose to children in this 12 to 15 age group. We can move to my slides, please, Sally. Thank you. So I'm going to go through two quick case studies and then reiterate what Scott's already talked about in terms of ECG abnormalities. So this is a typical presentation of what we expect to see, and the children both presented to emergency department. So a 16-year-old woke up in the middle of the night with sudden onset of chest pain, lasted for several hours, and then he went backwards to sleep until about 5 in the morning, when he woke up again with chest pain. So the pain was fairly typical. It was central, it was left-sided, there was no radiation, dull ache, no aggravating or relieving factors, mildly dyspneic, some mild nausea, but no vomiting. Next slide, please. Had no other symptoms of intercurrent illnesses, had been previously well up until that night. We had, importantly, no COVID contacts, no exposures within his family unit. And he'd received his second Pfizer dose 3 days prior. He tolerated this quite well, apart from a mild headache post second dose. No significant past medical history. Next slide, please. So examination was essentially normal. He had normal vital signs. He had no pericardial rub. His heart rate at the time of assessment at the initial emergency department was about 90 beats per minute, so not significantly elevated. He had an ECG performed, which we'll see in a second, and a chest X-ray. And the surprising feature was his troponin, which was 22,000, so significantly elevated. He was treated initially with Nurofen, paracetamol, colchicine, which resolved his pain quite quickly. He was in this adolescent age group in a sort of mixed emergency department hospital, and the plan had been to keep him there initially, but then was transferred to us at the children for further assessment and management. Further investigations with us on arrival, he had a COVID swab, which was negative. His white cell count was a little bit low. CRP was mildly elevated, which is something we're also seeing. Patient with similar presentation. His BNP was normal, and his ongoing or other assessments for other etiologies and other viruses in terms of serology were all negative. So this is chest X-ray. It's unremarkable, maybe slightly increased pulmonary vascular markings, but normal cardiothoracic ratio. And next, please. And here's his ECG. So you can see this quite widespread saddle-shaped ST elevation in his inferior leads and his lateral leads as well. So hopefully these will play. So here's a.
Can I just interrupt? Can we go back,
Yeah.
Sally? Sorry,
Yeah.
to ECG. We've got the echo there.
Yep.
That's it.
Maybe back
Sorry,
one.
this is probably the most important, I think. Thanks, Brent.
Yeah, sorry, my slides are a bit behind. There we go. Yeah, so fairly sort of widespread ST changes, which you can see, and we can see in lead AVR, second from the right at the top, he has this reciprocal changes there as well, with some PR elevation and some ST depression. Maybe next slide now, please, Sally. So we're on to the MRI. So the echo was essentially normal. We can see this is he went on to have an MRI, maybe because of his elevated troponin and some of the difficulties with some of his echo images. So this is a 4-chamber type view. We can see that he has a rim of pericardial fluid around the right ventricle and around the apex of the heart. But if we play the cine, we can see that his ventricular function is normal. And here's a short axis image, once again, a very small pericardial effusion, normal ventricular function. And then we've used some techniques to have a look for evidence of myocarditis. So this is a technique looking for tissue edema. So on this color scale here, we have edema represented with the blue. And so we're seeing these subepicardial areas of edema within the myocardium, both in the inferior left ventricular wall and the superior wall as well, mid-ventricular level. And then this is a technique called late gadolinium enhancement, which enables us to look for inflammation or fibrosis or scarring within the myocardium. So it's administration of gadolinium, and then you have to look and see whether there's any residual gadolinium in the myocardium. And you can see in the lateral left ventricular wall, there's some bright areas in the myocardium in this 4-chamber type view. And then in this short around the images earlier.
Sorry, Bren, we're having a bit of trouble hearing you. Did you want me to move to the next slide?
Yeah, sorry, can you go to the next slide? Sorry, I think my internet's a little bit.
Yeah, I think it is too.
Yeah, okay. Yeah, and this is just showing the superior enhancement. Next slide, please. So this is what we saw with troponin. So we did do serial troponins on him, and this is in the phase of trying to understand what happens with these adolescents. And you can see it fell quite quickly. So 4 days after presentation, his troponin was back to less than 1,000 from a peak of 22,000 on presentation. So it peaked quite early and then fell as we'd expect. Next slide, please. And we saw resolution of his ECG changes. So he has some very mild ST elevation at this point, developing some T-wave inversion in his lateral leads. This is what we typically see with the evolution of myocarditis. And so what we saw in terms of follow-ups, he went home after 5 days. He came back to us a month after his presentation. He remained asymptomatic, developed some T-wave changes, but his ventricular function and dimensions were normal at a normal Holter monitor. And he's been given advice to remain with limited limitations in terms of his physical restrictions until we review him in 3 months. And there's probably recommendations that he won't receive booster vaccinations with Pfizer or Moderna at this point. So the imaging was trying to represent that the changes that we see on MRI are very typical of what we see with post-viral myocarditis in the adolescent age group as well. So the troponin rise, the course of it, and the pattern of inflammation is very similar to what we see as well. Next slide, please. And here's his ECG when he presented to us in the clinic with this sort of evolving T-wave changes. We just move on to the second case quickly. This is a more straightforward case. Another adolescent, a 17-year-old. He and his twin had their second dose of Pfizer on the same day. And he developed central chest pain 4 days after his second dose. He had some dull ache with some intermittent sharp episodes from his description. Once again, no intercurrent symptoms, and he presented to an adult emergency department. And as we heard from Scott, tachycardia is an important symptom in this patient group and is an important sign, and his resting heart rate on presentation was over 130 beats per minute. Next slide. So ECG was his precordial or his limb leads, and no PR changes. Next slide, please.
Sorry, Bryn, we're not hearing you at all at the moment. I'm sorry.
Oh, sorry.
We're not hearing you at all at the moment.
Hear me now?
Yes.
So white cell count was mildly elevated, and he had a mild troponin elevation, so troponin of 2000. Once again, mildly elevated CRP, normal CK, and he had normal echocardiogram observed for 48 hours and treated anti-inflammatories prior to discharge. So just an illustration of someone who had really mild symptoms, but the key here was his resting tachycardia, which prompted the further investigations. We've already seen this from Nigel, the criteria that we use to classify these cases. Maybe to the next slide. So about pericarditis as well. Next slide, please.
Sorry, Bryn, are you talking? Again, are we just
Talking now? Yeah, I am. Sorry, I don't know why you can't hear me. Is that better?
I can hear you at the moment, yes.
Okay. So when we think about this sort of pericarditis, myocarditis involvement, I guess we think about it as a bit of a continuum from just inflammation of the pericardium through to inflammation of the myocardium. And clearly the pericardium is in close adherence with the epicardial layers of the myocardium. And so we do have this overlap between patients that have myocarditis or pericarditis alone and involvement of the pericardium and myocardium with each entity. Next slide, please. So I'll just talk quickly now in 3 minutes about ECG findings. Next slide. So you've been through this already. So the ECG changes we see in pericarditis, we generally see widespread concave ST elevation with PR depression. Involves the limb leads as well as the precordial leads. And then we'd expect to see reciprocal ST depression and PR elevation in lead AVR. And sinus tachycardia is quite common. One of the other describers, particularly if there's pericardial fluid or effusion, is low voltage QRS complex seen as well. So here's a very nice example, similar to the one we saw, very typical of pericarditis. So this widespread saddle-shaped ST elevation throughout the limb leads and the precordial leads as well. We can see in lead 1 that there's PR depression. If we look in PR, there's PR elevation and reciprocal ST depression. Next slide, please. So we've seen this link already from Scott's talk. We go to the next slide. So just to highlight one of the things that we see commonly in adolescents, an entity known as benign early repolarization, which can mimic pericarditis and can also mimic ischemic heart disease. This tends to be more prominent in the left precordial lead, so we don't tend to see these changes throughout the limb leads. It's also common in young, healthy patients. And we describe it as having a high takeoff or elevation of the J point, so that transition from the QRS complex to the ST segment. Next slide, please. Next. And once again, there's no reciprocal ST depression. So this is what we typically see with benign early repolarization. You can see it affects mainly the leftward precordial leads and doesn't tend to involve the limb leads. Next, please. And there are some discriminators which can be useful to try and help differentiate that. Next slide, please. So much more exaggerated ST elevation in pericarditis compared to benign early repolarization. Next slide. And this little notch, or what's called a fishhook appearance at the end of the QRS complex that we see with benign repolarization. Next slide, please. So just to finish with briefly myocarditis changes. So the most common thing that we see in myocarditis is sinus tachycardia, and have non-specific segment and T-wave change, severe conduction system abnormalities, so abnormalities in the QRS, duration, arrhythmias, and conduction delays within the sinus node. And as we saw in the first case, there might be some ECG features of pericarditis if that adjacent pericardium is inflamed as well. Next slide, please. So here's a similar ECG to what Scott showed, with just some non-specific ST changes. Doesn't really fit with pericarditis. It's a case of myocarditis. And next slide.
Okay, I think we'll we'll go to some questions at this stage, because we lost the last bit of Bryn, but that was very informative regarding a lot of the ECG things. There's some good questions coming through, and I think I'll start with probably one of the most common ones. Is the management of the person, if you're going to hold on to them as a GP, because the ECG is normal, your bloods are all normal, they've got a bit of chest pain. Looking at these cases, that it looks like it's quite a short-lived illness symptomatically, and so you treat for a few days. If they're possible or possible cases, because they've had symptoms but they've got normal ECGs and normal bloods, what would you recommend, Nigel, regarding the need for cardiologists to see, and then the vaccination? Is there a need, and is there would you basically be saying that these people can have a vaccine if they've had a normal bloods and a normal ECG?
Yeah, no, thanks, Scott. And that's part of the next part of the advice that's sort of coming and being updated at the moment. And again, just acknowledging this is something we're sort of learning about and data's emerging. So as I flagged, that US data has been really helpful. And, you know, we're expecting to see the peak actually very shortly with the second dose. So majority or the highest number are expected to receive with the second dose, and they don't need another vaccine. So they're very much going to be ones we're going to be monitoring and following up and don't need to be referred. What's tricky at the moment is that first dose. And I think we need to divide out the myocarditis from the pericarditis. I think the myocarditis pretty much universally will need to see a cardiologist and work out because they haven't had abnormal tests. So we need to sort out them before we give them dose 2. If it's pericarditis, we are seeing that in sort of a different age range. We are seeing men and women, but actually more women often having the pericarditis symptoms. And again, if all the investigations are negative, it probably is safe to proceed with that second dose. You could argue whether that's another mRNA vaccine. If you're over 60, clearly AstraZeneca, is also available and could be used. Or some may prefer to wait for another vaccine, which is going to be Novavax as a protein vaccine made differently, hope to be available and discussed sort of at the end of the year. Again, taking a bit longer than we thought in terms of some of the regulatory processes, but looks very good in the phase 3 trials. So they're the things we're juggling, but totally agree that completely normal investigations, reassured, no other features suggestive of pericarditis. We should be able to give you a way to proceed safely with dose 2, and we're just mocking up that as a bit of a flow chart, making sure the cardiologists are comfortable, and we'll circulate that in the next couple of weeks. So not quite there yet, but definitely agree that's a top question we're trying to work through.
Okay, I want to ask you a patient question. Has anyone died of this?
So again, it depends on by age. So we haven't had reports of deaths from that case series from the United States that I've recorded, but there have been some deaths in older individuals with myocarditis, temporally associated with the vaccine. So as I mentioned, that relates to, is this truly just the same syndrome that yourself and Bryn have nicely illustrated, or are there other causes of myocarditis, other complexities in older people that may be related to that presentation? So again, not easy to confirm that in terms of number of cases. There has been one case in New Zealand that was confirmed by their review panel and through their coroner that they felt it was vaccine associated in a 30-year-old, and that's been publicly reported. So very small number of deaths, and as mentioned, majority seem to recover. And just briefly while on the topic though, there was a comment in there about Singapore. There was someone in Singapore who had this pain, went to the gym, kept going, had a cardiac arrest, and getting intubated into ICU. And therefore, after that case, they actually came up with a broad recommendation, do no exercise for the week after the vaccine for everybody, which is clearly not going to work for most 12 to 25-year-olds who've been, in lockdown, particularly in Victoria for, a long period of time and want to do things after a vaccine. So it's very much awareness of the symptoms. We'll stop people having more serious adverse events if they listen to the symptoms, present appropriately to their GP and get investigated. So very low likelihood of death, but it is possible if we don't recognise it and manage it.
Thanks, Nigel. Bryn, I've got a question for you. What do you tell the parents and the adolescent regarding the use of the medications, and how long do they expect to be symptomatic? And what else do you tell them about their sort of exercise?
So in terms of non-steroidals, when we haven't seen many of these kids from a cardiology point of view, is that most of them are going home from the emergency department or GP, but most of their chest pain seems to resolve in a few days. And so we have only had them on anti-inflammatories for 5 to 7 days at most. There were a couple of questions in the chat about colchicine, so I might just address that quickly. So colchicine has been shown to reduce recurrence of pericarditis in adults. There's no data in children, so it's not something that we use routinely. There's certainly no data with this condition either in this post-vaccination pericarditis or myocarditis. So certainly from the Children's Hospital, our current recommendation is just to use anti-inflammatories for pain relief and for that pericardial inflammation. In terms of exercises, we've only seen a couple of children now in this acute phase. We certainly have restricted them from all exercise. So that first case we discussed for that period up until a month. And then who's been recommended to do some gentle, low-level exercise in terms of walking at most. I think it was a recommendation from the cardiologist until he has his next review. So that's partly because we're cautious about this and we're still learning about it.
And children and adolescents and adults who've got an underlying conduction defects such as WPW or QT conduction defects, are they still able to have the vaccine?
The vaccine? Yeah, absolutely. So there's really no, the only contraindication or relative contraindication are children who have inflammatory heart disease, which is rare, that patients with rheumatic heart disease, if they've just had an episode of myocarditis or pericarditis from another cause, would be cautious with that group. But certainly children with structural heart disease, repaired congenital heart disease through to sort of more complex forms, and children with long QT syndrome, conduction abnormalities, we're recommending they have the vaccine.
If the initial ECG is normal, by the way, and the patient's well, would you feel that the ECG, is there a chance the ECG is going to progress to being abnormal if the symptoms get worse, or is this sort of something that occurs quite quickly and tapers, or can it be a more progressed illness?
I don't know if we know enough yet, Scott, to answer that. I mean, the ones that we've seen seem to have changes, have troponin rises, and have tachycardia on presentation, basically. So they do seem to, when they present, they have the symptoms, they'll have signs of either pericarditis or inflammation quite early.
Thanks. Yeah, that's so it's interesting to see. Look, how often, if you've got a normal ECG, do you keep repeating it for a few days? And then if it's clear that things are improving, you can just say, look, your bloods are all normal, the ECG has been normal for a couple of cases, then we can just manage symptomatically.
I think so. And I think troponin is probably the key, because it's really, as we've said, there's going to be a lot of people who have some non-specific chest pain and may have some pericardial inflammation, but it's really the ones who have myocarditis or involvement of the myocardium that we want to be cautious about.
I think many of the questions have already been answered in the talk. It's quite interesting. There's very little in the way of predisposing factors that will give us a clue, and that prior cardiac history is really not a sort of precursor for avoiding this. So we don't have really much of a idea on the kind of people that will end up like this, apart from at this stage the gender and the age groups. And Nigel, do you have any other comments at this stage?
No, Scott, I agree with Bryn. I think we're sort of learning, more about this. And again, it has been a good, collaboration with GPs and emergencies to try and understand it a little bit better. Nick Cox from Western Health's been really helpful from the adult side as well, acknowledging, Scott, I think I'll touch base on that sort of acute cardiac syndrome. We certainly have had some acute infarcts occur in the window post the vaccine, including a couple of deaths, unfortunately, temporally associated post-vaccine. So I think you're right. We might end up needing to nuance the guidance a little bit for the pediatric population, particularly once we look into those younger age groups compared to that, 30, 40-year-old where you're still, although EDs are kind of balancing that. So I'm not sure about if you want to comment further on that. That's probably one differential we're trying to get through in terms of that acute, advice and follow-up.
Just the length of time for the anti-inflammatories. The anti-inflammatories they're predominantly symptomatic. They're not really as part of treatment. Is that correct?
I think most people would give them. I guess the kids we've seen have responded quickly in terms of their pain. Yeah, I guess that's what we've seen. And, we're not doing serial CRPs on these children. We're not following their inflammatory markers. Mm-hmm. But I think most of us would give a defined period of 5 days as an arbitrary course of anti-inflammatories. And less likely to obviously get the gastrointestinal problems that we see in adults in our population as well.
All right. Look, thank you so much for your presentation, Bryn and Nigel. And so what we'll do now is we'll conclude the talk. Don't forget to fill out the survey. If you fill out the survey, you put in your RACGP or Aquam points number, you'll get some points for attending tonight's webinar. So so thank you so much for everyone attending, and thank you again for Bryn and Nigel. Thank you.
Thanks.
Thanks, Scott.